Great, thank you, Oliver. Thank you very much to the organisers for the invitation to speak. So I'm Andy Turnbull. I'm a consultant in paediatric respiratory medicine at Great Ormond Street, and I'm the lead for the complex asthma service there. I've got a bit of a cold, so please bear with me on the croaky voice. Next slide, please. Thank you. So this is a chance to go through clinical updates in the last year and look at any publications since then, of which really the main one has been the Global Initiative for Asthma annual report that comes out yearly, so we can focus a little bit on that. But actually many other publications are either slightly more dated or anticipated. So we'll talk a little bit about the severe asthma guidance within the current GINA report that was previously as a separate short guide. And we'll talk a little bit about the ERS diagnostic algorithm from 2021, or diagnostic guidelines, sorry. And then, of course, the BTS sign NICE combined guideline for the diagnosis monitoring and management of chronic asthma is due to be published in November this year. That is a much anticipated joint effort from BTS Sign and NICE, and we can talk briefly just about some of the draft guidance within it. Next slide, please. So that I'll just begin on that because it is worth knowing about and people having a look at the draft guidance on the website if they're interested. Obviously, the need for a combined guideline is really around UK practice and the fact that there has been some discrepancies between the NICE and BTS guidance currently in existence. That guideline will cover asthma from childhood through the life course and focus particularly on updating evidence and making recommendations around diagnosis, pharmacological treatment, monitoring, as well as a few other points. The draft consultation guidance is available on the NICE and BTS websites, and indications of the recommendations they'll make, but the final publication date is November. Next slide, please. And we've already heard from Dr. Jen Townsend this morning about the efforts of the national bundle of care for children and young people with asthma, and that's a really important program of interventions and recommendations. And I want to just talk specifically about within those ones the three ones that are highlighted. Sorry, next slide here. So we'll talk in this talk really about accurate and early diagnosis, effective preventative medicine, and briefly about severe asthma. Next slide, please. So Dr. Townsend highlighted some of why some of the importance of reaching an accurate and early diagnosis early on, and why that can be challenging. I'll talk a little bit more about that because it really is so key to clinical practice in asthma, and an important thing that we address in severe asthma services when children are referred to us. Why is it challenging? Well, the diagnosis of asthma is made on the basis of a typical characteristic clinical history, so symptoms of breathlessness, chest tightness, wheeze and cough that vary over time and in intensity and severity. But really it must be supported by evidence of expiratory airflow limitation and or airway inflammation, ideally both. There's no single gold standard test for asthma, so a number of different tests have to be employed to support that clinical diagnosis. It's really important because many other respiratory conditions can present with similar symptoms and can masquerade as asthma, and it is important to distinguish those. And it's also important to recognise that asthma is a chronic disease with variable symptoms and variable physiology, and therefore variable test results. So testing someone's spirometry, bronchodilator reversibility, and FeNO on any given day will vary depending on response to exposures, and particularly in response to inhaled corticosteroid containing treatment. Next slide, please. Why is it so important that we be clear about the diagnosis? Well, we've already heard from Dr. Townsend that under and overdiagnosis of asthma is common. Underdiagnosis can lead to delayed treatment initiation, delayed opportunities for education, trigger avoidance, understanding about the condition, excess morbidity and poor quality of life for the individual affected, and of course placing the individual at high risk of asthma attacks if they're untreated. And persistent airway inflammation, airway remodeling can all impair future lung function growth. Overdiagnosis is also important and also unfortunately common. That can lead to exposure to unnecessary medications with associated side effects. Importantly, other conditions that may be mimicking asthma can be missed and appropriate treatment initiation delayed, and there's a healthcare cost associated with that. Next slide, please. So the diagnostic pathways that I think are sort of relevant for clinical teams practicing in the UK at the moment would be the NICE 2017, the BTS Sign 2019 diagnostic algorithms. There's some differences in those, and that NICE have a greater emphasis on objective testing. The ERS diagnostic pathway, again, quite similar to that produced by NICE, with an emphasis on spirometry and FeNO as part of the objective testing pathway. And then the GINA 2024 algorithm, again, emphasizing the importance of objective testing where that is available. And of course, GINA being a global guideline, acknowledges the pragmatic approach that must be taken, in that not all settings where patients are treated have access to spirometry or even peak flow variability. What GINA helpfully does do is make some recommendations on the practical steps to establish a diagnosis when either no objective testing has been done at the point where the patient was first seen, or if the patient has subsequently been started on treatment and test results are then normal. So there's some useful things to go through in that. Next slide, please. This slide I wanted to put up to illustrate the variability of asthma lung function over time. And this is important because it illustrates that there will be periods in anyone's day-to-day life who has asthma where they will feel better control and then worse control, and then have exacerbations in response to viral triggers or other airway irritants. And it is important because that has implications on testing. So of course, if we were to test somebody's lung function at a time when they're completely well, it may well be that spirometry is normal with no obstruction and no bronchodilator reversibility, but it could be very different at another time. So illustrating that where the clinical suspicion of asthma is high, negative tests cannot exclude it. Next slide, please. This slide illustrates the NICE diagnostic algorithm, beginning with a child who has symptoms suggestive of asthma. The first test recommended is spirometry, going on to do bronchodilator reversibility if there is an obstruction present. That then takes you down the right-hand side of that algorithm. And of course, if there's airway obstruction, which is reversible, then a diagnosis of asthma can be made. If not, FeNO then is recommended. And if FeNO is high, indicative of eosinophilic airway inflammation, then a period of peak flow variability or some other test to demonstrate kind of variable airflow obstruction is again recommended. If that can't be demonstrated, a suspected diagnosis of asthma can be made, and then a treatment trial with monitoring of response is recommended. If there's no airway obstruction, FeNO is again recommended as a test to do next, and again looking for peak flow variability depending on the outcomes of the FeNO testing. So this is a useful diagnostic algorithm emphasizing the value of both looking for airways obstruction, bronchodilator reversibility, and evidence of eosinophilic inflammation, indirect evidence, and basing treatment either on some combination of those along with maybe a response to therapy. Next slide, please. This is the ERS algorithm. We won't dwell on it. It's a busy slide and it's available online to look at. But really, the important point to make here is that the algorithm is actually very similar, utilizing the same tests in a broadly similar order, but with slightly different cutoffs. So whereas NICE look at a FeNO cutoff of 35 parts per billion as being positive, the ERS recommend a cutoff of 25 parts per billion, and again they use slightly different ratios of FEV1 to FVC to determine airways obstruction. So again, NICE having a lower ratio, ERS having a higher ratio, and that just reflects, these are continuous variables, obviously FeNO and FEV1 to FVC ratio, and where you choose your cutoff just influences the sensitivity and specificity of your test in different age groups or different populations. Next slide, please. This is the GINA guidance, again focusing on a child with a person with typical symptoms, recommending spirometry and bronchodilator reversibility in the middle column of that table. Peak flow availability if spirometry is not peak flow variability if spirometry is not available. On the right hand side is testing for alternative diagnosis if there is evidence for those. And on the left is a series of then recommendations to be made if either the patient needed to have treatment initiated early before objective testing could be done, or if subsequent objective testing on treatment is normal. Next slide, please. So that these recommendations are sort of broadly what are outlined in GINA, and I think they do reflect a really pragmatic and helpful approach, that it can be very common that a patient has a diagnostic label of asthma, historically from perhaps early in childhood, and has been started on ICS containing treatment, may or may not have symptoms continuing, but lung function on treatment, spirometry and FeNO may well be normal. And that is a setting or a situation which we encounter very commonly in patients referred to severe asthma services, potentially perhaps because symptoms have continued and treatment has been escalated, but without symptom control. So again, always going back to reviewing the history. Do the symptoms remain typical of asthma? Is that still the most clinically likely diagnosis? And then obviously repeating spirometry, making sure that if feasible for the patient, that SABA, so short-acting beta-2 agonists, and long-acting beta-2 agonists are withheld for an appropriate duration. Assessing between visit FEV1 and any variability in that on changes in bronchial responsiveness. And then considering stepping down if the patient's symptoms allow for it, considering a managed step down of inhaled corticosteroid treatment with review of spirometry and BDR after 2 to 4 weeks, of course with safety netting. But this is a really pragmatic and I think an appropriate recommendation. And then of course considering referral for bronchial provocation tests. If at any point the symptoms are suggestive of an alternative diagnosis, then of course investigating and referring on for that. Next slide, please. I think the key messages I want to make about accurate and early diagnosis is really to say that this is a key issue. Always make sure that, you know, if in any patient with asthma, evaluate is the diagnosis supported by objective testing. If not, can we revisit that? And thinking about the effect of current treatment that might have on test results. Recognizing that asthma is a disease characterized by variability, it's sort of inherent within it. So consider repeating testing if there's a high clinical suspicion. And then also just that last bit about sort of thinking about interpreting tests in the clinical context, and remember that the cutoff values are somewhat arbitrarily defined, and if the history is very suggestive of asthma, then considering your test results as part of an entire package rather than individually. Dr. Townsend again talked about some of the important work within the national bundle, and I think this is really key. So firstly, you know, in terms of requirements that enable accurate and early diagnosis, we need consistent and I guess clear guidance, and I hope that will come in the form of the combined BTS sign and NICE guidance, and that can both clarify processes, but also kind of make enable people to make a stronger case for resource allocation. And then the importance of access to objective tests. So the work done to create and establish diagnostic hubs with appropriate training and equipment for children and young people is really important here, as well as pathways to enable patients in primary, secondary care to have their care escalated as and when needed. And that might, you know, not be equal in all parts of the country. So we need to ensure that there's always access and availability of secondary and tertiary care. Next slide, please. Moving on to preventative medicine, again, another kind of key stream of the bundle, so effective preventative medicine. Thinking about the aims of asthma treatment. Symptom control is certainly one of them, so the absence of symptoms day or night, no limitation in activities, no requirement for rescue medication, and normal lung function. But risk is another really key element here. So making sure that we are considering someone's risk of asthma attacks and minimizing that. The risk of low lung function persisting throughout the life course, again, is a risk we must be focused on, and risks of side effects from medication. And it's not simply enough to look at symptom control as a surrogate for risk, because patients with few symptoms can still be at risk of asthma attacks, and we've known that from historic data. Next slide, please. This slide really, I think, illustrates the key processes in asthma care. So review, assess, and adjust. So reviewing symptoms, exacerbation frequency and history, side effects of medications, like lung function comorbidities, and particularly what's important to the patient. Confirmation of the diagnosis under assessment if necessary, symptom control, comorbidities. Inhaler technique is a vital aspect of making sure that people understand and are able to take the medicines that are recommended, and if not, then we review what are the alternatives, and always thinking about the patient preferences and goals. Treatment of modifiable risk factors and comorbidities, looking at non-pharmacological strategies and adjusting medication and skills and education to go with that as part of the adjustment. And that's a continuous cycle. I thought the talk from Ian Sinner earlier was fantastic, and looking at their process for annual assessment reviews of patients and really incorporating all of this in a very patient-centered way is exemplary of, I think, how that can be done. Next slide, please. We'll move on to talk about effective preventative treatment and the pharmacological treatment options, particularly really focusing on this shift that has happened in the last 5 years in asthma guidance, initially through the GINA recommendations and then with other guidance following, away from treatment with short-acting beta-2 agonists only, and always focusing on inhaled corticosteroids or the treatment containing inhaled corticosteroids from step 1. So in mild asthma, that can be symptom-driven. In moderate or severe asthma, then that would be regular daily inhaled corticosteroids. And that's based on concerns with safety over SABA-only treatment and the strong evidence for inhaled corticosteroids reducing exacerbation risk, and particularly risk of severe exacerbations. Next slide, please. This is a publication that I think will be known well to many in the audience, and is always something that we need to bear in mind when we talked about when we had the presentation on the National Child Mortality Database, recognizing that the UK is still one of the countries with the poorest asthma outcomes and mortality rates in Europe, and we need to, all of these strategies need to be taken in mind to address this particularly. When we think about SABA overuse, it's important to recognise that among patients who died and whose deaths were reviewed in the National Review of Asthma Deaths, many were underreported in terms of their asthma severity, considered to have mild or moderate asthma. There was inadequate corticosteroid prescribing in a large majority, and SABA overuse in 40% nearly. Next slide, please. Excess SABA has been associated in lots of studies and lots of kind of national database registries with higher risk of exacerbation. So this data on the right show that data from Sweden, where patients across different GINA asthma steps of treatment, so step 1 to 4, who had the highest issue of issue of salbutamol inhalers per year with the greatest risk of exacerbations. And we know that there's, from pharmacological studies, that there is toxicity associated with SABA overuse, so increased airway hyperresponsiveness and reduced bronchodilator effect. And beyond the kind of registry association data and the any pharmacological studies, the important additional point that really GINA take into account in the shift of treatment emphasis is around consistent messaging. So patients at step 1, if they are used to relying on a short-acting beta-2 agonist as their only therapy and the relieving effect of that, but are then at step 2 asked to take a regular maintenance treatment when they may or may not be symptomatic, that's confusing, and I think risks patients over relying on salbutamol. So that's, I think, another important element of why the recommendations are made. Next slide, please. The evidence for inhaled corticosteroids from step 1 is robust and has been present for decades. We've seen large randomized controlled trials of regular low-dose inhaled corticosteroids in adults and children with mild asthma, so infrequent symptoms, and those have been shown to reduce exacerbation rates or rates of severe exacerbations by half, and also improve quality of life and symptom scores. More recently, we've had larger studies of the use of a combination of anti-inflammatory reliever therapy. So this is a combination of steroid and a long-acting steroid with a beta-2 agonist, short or long-acting, in a combination inhaler, and then either used as needed in as step 1 treatment or as part of maintenance and reliever therapy. But what the most well-known inhaler combination would be budesonide formoterol, and that's a inhaled steroid with a long-acting beta-2 agonist, which is fast-acting, so it's got a quick mode of onset, and can be used as reliever therapy. Or there's inhaled corticosteroid with salbutamol, or albuterol, short-acting beta-2 agonist, and we'll talk about some of the evidence behind those studies. Next slide, please. So in the adult and adolescent age groups, patients above 12 years is where the most evidence exists for anti-inflammatory reliever therapy. I want to just, highlight at this point actually that last year's talk in the Ask About Asthma conference by Louise Fleming is a fantastic resource where she goes into this in depth. So I encourage anyone for more information just to go through that. But I will just touch on a few studies here to kind of make this part of a shorter talk. So just to go back to anti-inflammatory reliever therapy as needed, there is data in adults and adolescents from several studies showing that using that combination compared to salbutamol alone is associated with a 55% reduction in severe exacerbations, so those requiring systemic steroids or hospitalization. And compared to a strategy against a strategy of daily inhaled corticosteroids and as needed SABA, so short-acting beta agonist, there's no significant difference in the as needed anti-inflammatory reliever treatment in terms of exacerbation rate. So it's not in the meta-analyses, it's not inferior to a strategy of regular low-dose inhaled corticosteroids with as needed SABA. Next slide, please. What about anti-inflammatory reliever therapy as part of maintenance and reliever therapy? So this is getting on towards step 3 and 4 of GINA. Step 2 of GINA onwards. We'll come to this in a minute. Step 3 of GINA, step 3 and 4, because step 1 and 2 are combined. In patients with this is the data from again adults and adolescents. So in patients with poorly controlled asthma, those who are not managing on step 3 of GINA treatment, then the comparison of maintenance and reliever therapy compared to standard step 4, so inhaled corticosteroids with LABA and a short-acting beta-2 agonist. Again, maintenance and reliever therapy was found to reduce exacerbations by 29%, the risk of severe exacerbations. Next slide, please. What about the pediatric data? There is certainly less of it, but it is important what data there is out there, and I think this is a growing picture, and there are certainly some important and well-needed studies in the running. So anti-inflammatory reliever therapy as needed, so at early steps in asthma treatment. This is the results of a study called the TREXA study, which was done in children 5 to 18 years old with 4 arms where patients were allocated either to have an inhaled corticosteroid or inhaled corticosteroid with LABA combined with SABA combined as their controller. With LABA, and then to have an inhaled corticosteroid SABA or SABA only reliever. And essentially what we saw from that study was that the group who had SABA only as their treatment, so they were on a placebo maintenance inhaler with SABA only as their reliever, did the worst. And all other groups who had inhaled corticosteroids as part of their maintenance or as needed treatment did better. The group who did the best in terms of exacerbation frequency or treatment failure, which was hospitalization or steroids, was the group who had regular inhaled corticosteroids. So based on this study, that remains the most optimum treatment strategy in children. But for those who perhaps either have difficulties with adherence, which we know is common, then maintenance and reliever therapy with an inhaled corticosteroid preparation is a good strategy based on this trial. Next slide, please. What about air as part of maintenance and reliever therapy? There has only been one study in children under 12 years, and that was done in a group of children who were randomized into 3 study arms. So they either had a fixed combination of budesonide formoterol as a once daily treatment and as their reliever. They had that combination as their maintenance treatment with a short-acting beta-2 agonist reliever, or they had a fixed combination of a fixed dose of steroid only with SABA as their reliever. And the MART group did the best, again, showing a reduction in exacerbation rate by 70 to 79% versus the other 2 groups. So supportive of MART in the younger pediatric age group. Next slide, please. This table just outlines the doses of what are referred to in low, medium, or high dose treatment according to the GINA guidance, and I think it's just important to read this, be aware of this, in addition to the following slides. Next slide, please. So these are the GINA treatment tracks in the current 2024 guideline. This is the guidance for the adolescent and adult age group, and what we see is that GINA makes recommendations based on a preferred option and an alternative option. And the preferred option, known as track 1, is for steps 1 and 2 for there to be as needed low dose ICS formoterol so that's the symptom reliever, or used in response to symptoms. And then for the main reliever, for that to be the same low dose ICS formoterol. At step 3 and beyond, this is added in as regular treatment, so low dose maintenance ICS reliever, but then with the same inhaler as their reliever, and in step 4 the same. The alternative option is to take inhaled corticosteroids whenever SABA is taken, and this is the track 2 option. And then step 2 in track 2 is to have low dose maintenance ICS with a reliever that can either be a combination of ICS SABA, which actually we don't have available in the UK licensed currently, or as needed SABA. Next slide, please. And then looking at in the pediatric age group, the younger child age group below 12, where there really is less evidence to firmly recommend maintenance and reliever therapy at step 1. The recommendation here is still to have anti-inflammatory reliever therapy, so low dose inhaled corticosteroids whenever SABA is taken. With step 2, moving on to daily low dose inhaled corticosteroids, and step 3 and 4, a combination of either medium dose ICS or low dose ICS formoterol, and then moving up in terms of ICS strength with the addition of LABA in steps 4 and upwards. And again, for steps 3 and 4, based on the evidence that we do have, and depending on patient availability, then maintenance and reliever therapy with an ICS formoterol is recommended, but before then, as needed SABA is recommended. So I think it's an evolving story. Sorry, next slide. The rollout, the evidence base for particularly the younger child age group is an evolving story, and we will have hopefully more evidence in the next few years to make clearer changes in some of the recommendations for children under 12 years. But the current recommendations, again outlined in GINA, show some of the inhalers that are available. And for the age group of 12 and up, there are licensed preparations of budesonide formoterol. The 206 or the 106 inhalers are available. And then the next slide, please. But for the pediatric 6 to 11-year-old age group, there are no licensed ICS formoterol preparations available. And this is important because I think there's good basis to trial this therapy in somebody who perhaps is an older child, 10, 11, who may be able to use a dry powder inhaler, but we must recognize that this is always about patient ability and what is the right inhaler for the patient. Use of those medications will be off-label, but in the new, at least draft consultation of the BTS Sign NICE guidance, a MART therapy for the younger age group than 12 is recommended if it's thought to be appropriate for the patient. Next slide, please. I think this is going back. Can I progress one slide forward, please? Great. So severe asthma, I'll go on to talk just briefly about this in the last few minutes. So Dr. Louise Fleming is going to give a talk on severe asthma later, particularly talking about patients who maybe are not being referred. I just want to highlight some of what is done in a severe asthma service, just to give a short window of insight into that. So severe asthma is asthma where there is poor control of symptoms or continuing frequent or severe exacerbations despite high dose treatment. Estimating prevalence of severe asthma in children is quite difficult. I think some studies have estimated it to be 2 to 3% of children with asthma, but that is probably an underestimate. They are a group with high vulnerability and high treatment burden and a high attack risk, I guess, as part of by definition almost, but also high risk of adverse effects. They have high healthcare utilization, and they are a group that need careful MDT considered evaluation. Next slide, please. These are the currently updated referral criteria on the National Asthma Bundle, and these reflect referral criteria that have been in place, I think, for a while, but it's really important that these are well circulated and well known, and really these referral criteria emphasize the importance of patient who's having any more than 2 attacks requiring steroids in the last year, any admission to PICU, persistent poor control in terms of symptom reporting and asthma control test scores, or persistent airways obstruction, but also highlighting that there can be other reasons for referral if there simply is concern from clinical teams involved in patients that their needs are not being met, that they have diagnostic uncertainty, that there are other adverse exposures that make that child or young person more at risk of adverse outcomes, then those patients should be referred. Next slide, please. What typically happens and what happens in our severe asthma services along these lines. So talking about comparing the diagnosis, we always will revisit that at the point of referral, making sure that we understand how and on what basis the diagnosis has been made, and we'll always repeat many of the physiological tests, looking for alternative or additional diagnoses that might make asthma worse, or that may exist instead of asthma, and treating those accordingly. And then evaluating the child with difficult asthma with a whole MDT of clinical nurse specialists, physiologists, physiotherapists, psychologists, making sure that we've assessed the child's environment and home and school, thought about comorbidities and managed those where appropriately, revisited diagnostic evaluation if need be, and gone through medication delivery and understanding and adherence, so that the patient is on the right medicine for them. And then looking at anything else in the school or in the peripheral health environment. In many cases, about 70% of cases, most children will end up with a diagnosis of asthma that might be determined by as difficult asthma, where things can be improved in any of those domains and symptom improvement can be seen. There will be some patients who will go on to be identified to have severe therapy-resistant asthma, and they would be considered for biologic eligibility. This slide is my, next slide, which I think is my penultimate slide. This slide just lists the biologics currently available for patients in childhood and adolescence, and we have 4 biologics available depending on age. I'll go through to my next slide, please, which is my last. So in summary, this talk, I hope I've covered the importance of accurate and early diagnosis and how that really must be supported by objective tests and should be revisited when there's any doubt, and referrals should be considered if the diagnosis can be difficult to establish. Effective preventative medicine really from step 1 should contain an inhaled corticosteroid, and there's strong evidence for anti-inflammatory reliever therapy in patients over 12 and growing evidence for that treatment approach in younger children. For severe asthma, for patients with severe asthma, either with poor control, severe attacks, high salbutamol use, low lung function, refer. Thank you for your time, and I'm happy to take any questions.
Fantastic, fantastic, Andrew. Thanks so much as always, very helpful to hear you speaking about this. We've got a few questions. So yeah, no panel this time. It's just your panel of one.
Sure.
So we're going to jump straight into some questions that have been put into the chat. So first one up. So colleagues put at Tuesday's primary care webinar, they said that the new NICE guidance will mean peak flow monitoring is not needed due to either not being conducted properly by the patient or not being conducted regularly. Some people find it a useful method to help towards diagnosing and, I would add, monitoring asthma. What's your view?
Yeah, I think that in the diagnosis and monitoring, there is still a place for peak flow. I think again it comes back a little bit to access to alternative tests. So obviously in making a diagnosis, I think that spirometry and measurement of FeNO are really crucial. But where those aren't available, or where there's a delay in getting those, then making use of a time where there's some delay by getting a period of peak flow variability monitoring is helpful. I think that and again, in a global sphere, it's a useful test. I think showing variability in airways obstruction with a high day-to-day variability or high diurnal variability is helpful. We don't do it a lot in a tertiary service, but of course we have to recognise most patients are being seen in primary care, and I think in that setting there can be value in that.
Yeah, I would agree with that, and I think for those of you who are in London, certainly can't speak for the rest of the country, but our kind of steer in London is that peak flow is actually valuable. So this is the London Asthma Leadership Implementation Group. We feel very much that there is a place for peak expiratory flow. Yeah. So we would see the comments that NICE have put more as kind of caveats to the use of peak flow monitoring rather than reasons to exclude its use.
I think that's a good assessment. Yeah.
Yeah. So yes, do continue. And a colleague often points out, a member of the group often points out to us that frequently your peak flow readings will drop before you can hear clinically audible wheeze. So that's just something to kind of be aware of as a kind of way of assessing severity of asthma. You clinically would see a drop in peak flow before you could hear wheeze, which I think is quite an interesting piece of information for those of us who deal with acute exacerbations.
Yes.
Oh, good. glad I'm not talking nonsense.
I agree.
Fantastic. All right. So okay, here's one here about when do we use just SABA and not have ICS also? And the person has said that they're thinking more about viral induced wheeze here, so they're recognizing that this isn't a first-line treatment for asthma, but there may be some cases where just using SABA is appropriate. How do you decide?
I think that once a diagnosis of asthma is confirmed and and the patient has symptoms, I think there is no real case anymore for SABA only treatment. So the treatment should contain inhaled corticosteroids. The question of viral wheeze or preschool wheeze is a different one, because of course then the response to treatment, there may not be some who need inhaled corticosteroids depending on the sort of the phenotype there. But I think that if there is a suggestion that particularly the patients with preschool wheeze that have a high risk of going on to develop asthma, so they have positive family history, there's evidence of air allergen sensitization or blood eosinophilia, or and they're having exacerbations that are requiring them to see healthcare providers, and particularly if they're receiving courses of oral steroids or having emissions, then actually a trial of inhaled corticosteroids is appropriate for that preschool child. So I think that only, if any of those criteria are met, I think a trial of inhaled corticosteroids is appropriate. SABA only treatment really, it doesn't have a place in many patient groups.
Yeah, really helpful. And I think definitely a kind of steer at national level as well around this. I sort of feel like you can use SABA only in a preschool child the first time you hear wheeze, and then any time after that you should probably be thinking about whether it's something else.
I think that's exactly right. Exactly. I think by the time you've seen them twice, by the time they're coming in unwell, particularly if they're going to the emergency department, they need further evaluation and consideration for, is this some other causal wheeze, or do they have preschool asthma?
Yeah, I think a steer again, London region. The steer is that if it's a couple of presentations in the course of a year, that they should really be going for a second opinion through through a respiratory specialist, just to if we feel less comfortable about sticking that label on a 3-year-old, it is important to make sure that somebody is considering it, and that means refer.
Yeah, I think that's a very reasonable approach.
Lovely. Oh, sorry. Get back to my questions. Apologies, Andy. Okay. Oh yes, a couple of people asked about this one. So what's recommended clinically? What is recommended if clinically a patient is well on their established preventer inhalers, but on their review their FeNO is high? This person says, I've seen patients in clinic who are well, not using the salbutamol, etc., but their FeNO is really high, maybe 50 to 90. Don't want to treat the number, but they do find the decision making confusing. What would be your kind of thoughts?
Sure. Yeah, exactly. But I think that is an important principle of not treating the number. But I guess it's the whole package here, isn't? And really, it's going back to if the patient's symptoms are controlled, so they have few symptoms, and their exacerbation, and their risk, particularly their risk of attacks, is low. So they have not had they have no history of severe attacks. They are have a good understanding of their medications, and they would by they're at least collecting regular prescription refills, indicating that they're probably taking them, and they're not exposed to adverse exposures or allergens. Then if symptoms are controlled and attack risk is low, then I think I wouldn't escalate treatment based on FeNO. But if symptoms are low and there are elements that lead you to be concerned that the person is at risk of attacks, then a FeNO I think has then that risk, i.e. they've had previous attacks, and you have a child with a high FeNO and you think, well, there's evidence of eosinophilic inflammation here, it would be the attack risk that would encourage me to be thinking about having a conversation with the child and their family about treatment escalation, or looking perhaps at adherence. Is the treatment being taken? Is it being understood? Is the delivery device appropriate for the child? Are they using a spacer? So really thinking about symptom control and attack and risk rather than FeNO itself.
Thanks, Andy. I think that clarifies that. And then just a very last quick question here. So I think there were plenty more, Andy. I'm just going to ask if you have a few minutes after we wrap up here, if you wouldn't mind. There's some questions still in the chat that we haven't got around to. If you just have a minute, I'd be really grateful if you could. I can
field those. Yeah, sure.
Maybe field some of those. And then just this last one, I think this is generally a question about MART. MART and its use in children, and this one specifically says, is there any evidence that MART is better than ICS and SABA if symptoms seem mild? For adults, we use MART regime so much more now. I think probably could broaden that out into should we be using MART more often in children, but mild, but also more broadly. What's your thoughts?
I think that there is evidence in adults that for mild symptoms, MART might be superior to regular ICS and SABA. I think in children, that again, just highlighting the fact that we have minimal data from the Trexas study, at least the children who had regular ICS did best, and so from the evidence that we have, actually you'd say that being on regular ICS is important, but we all know that adherence can be difficult, and particularly adherence in somebody who has infrequent symptoms can be difficult. So I think it's then about an individual conversation and thinking about patient-specific appropriate treatment until we have, there will of course be more evidence for this, but I think both are appropriate strategies.
Fantastic, thank you. Thanks for that, Andy. And then I think just being aware that MART as maintenance and reliever is part of anti-inflammatory and reliever approaches, and there's MART and there's anti-inflammatory reliever as required, as kind of different approaches which could be utilised.
Yes.
So yes, it's been really really helpful. So many questions, I think, always pop up around this, very sort of specific kind of clinical questions. So
yeah, sure. It's, I mean,
yeah.
I think it's just being embedded. It's you know, people, this is being embedded in clinical practice, and of course, you know, just the sort of practicalities of rolling it out can be challenging.
Yeah, absolutely. And I think so there is a move towards it. And then there was a question about plans for MART as well. So just as a bit of a, so there are some that exist. Asthma and Lung UK do have plans out there for MART.
Yes.
And in for those of you in London region, we are watch the space. We have we will be kind of publishing our kind of regional plan, which we hope to then have in all utilised in all sectors, along with as required anti-inflammatory reliever therapy plan as well. So yes, whoever had asked that, we will have them in London, and we will make them available as soon as. Sorry.
Well done.
Thank you, Andy, for joining us. Really appreciate your input.